Hello everyone. Today we begin a new section of our topics, the thorax and lungs in examination. Last times we learned a general examination of the body and now begin specific examination, and we begin with respiration system. You know that respiratory system has very important role on our life. As Romanian philosopher says, Ovidi, dum spero, it by Latin means, before I am breathing, I have hope that I am living. The process of physiological respiration includes two major parts, external respiration and internal respiration. External respiration, also known as breathing, involves both bringing air into the lungs, it means inhalation, and releasing air to the atmosphere. It called it exhalation. During internal respiration, oxygen and carbon dioxide are exchanged between the cell and the blood vessels. Respiration begins at the nose or mouth, where oxygenated air is brought in before moving down the larynx, and the trachea. The trachea branches into two bronchi, each leading into a lung. Each bronchus divides into the smaller bronchi and again into the smaller tubes called bronchioles. At the end of the bronchioles are air sacs called alveoli, and this alveoli, and this is where gas exchange occur. Before we begin learning respiratory respiration system, I'd like that you know and be familiar with terms of respiratory systems. As we mentioned it, respiratory system is the body system responsible for gas exchange between the body and the external environments. Pharynx or throat is a tube connected the nose, mouth to the esophagus. Larynx, its second name voice box, is a tube forming a passage between the pharynx and trachea. Trachea is a tube connecting the larynx to the bronchi of the lungs. Bronchi, the branches of tissue stemming from the trachea. Bronchioli is an airway that extends from the bronchus. Alveoli is a structure of the lung where the gas exchange occurs. And at last, diaphragm is a thoracic muscle that lays beneath the lungs and aids in inhalation and exhalation. Also, it's very important you know the landmark of the chest. Well, there is a picture where we can make these landmarks. There is vertical landmarks and horizontal landmarks of the chest. From vertical landmarks, it's very important this mid-sternal line. The second important vertical landmark is mid-clavicular line. Examination of the is the anterior axillary landmark of the chest well. To make vertical location, you must be able to count the ribs angle of the sternum. The sternal angle, the second name of this angle is Lewis angle. Also termed the divided angle of Lewis is the best guide into posteriorly. The 12th rib is another possible starting point of counting ribs and interspace. It helps locate findings rib on the lower posterior chest and provides from the second the anterior approaches ribs because first the rib are concealed between note that the costal cartilage under the claviculi. Of the first 7 ribs articulate with from the posterior, the cartilage of the 8, 9 is vertebral line here, 10 ribs articulate with the costal cartilages just above the middle part of the scapula. 11 and it's very important, and so 12 ribs are the floating ribs, have no anterior attachment. The cartilaginous tips of the 11th rib usually can be felt laterally, and the 10th ribs may be left posteriorly. On palpation, costal cartilage and ribs feel identical. The trachea bifurcates into this main 7, 8, and at the level of the sternal angle anteriorly, and the this T4 spinous process posteriorly. We say about this that 8, 9, and 10 ribs are articulate with the costal cartilage, and 11th and 12th ribs are floating ribs. Anteriorly, the apex of each lung rises about 2 centimeters to 4 centimeters above the inner third of the clavicle. The lower border of the lung crosses the 6 ribs and the midclavicular line, and the 8 ribs at the midaxillary line. Posteriorly, the lower border of the lung lies at about the level of the T10 spinous process. On inspiration, it descends further. Oblique fissure may be approximated by the string that runs from the T3 spinous process oblique down and around the chest to the 6 ribs and the midclavicular line. The right lung is further divided by the horizontal minor fissure anteriorly. This fissure runs close to the 4th ribs and meets the oblique fissure in the mid-axillary line near the 5th ribs. For examination of the respiratory system and of the chest, we must know these terms. Supraclavicular, it means above the clavicles. Infraclavicular, below the clavicles. Interscapular, between the scapulae. Infrascapular, below the scapulae. Basis of the lung, the lowermost portion, upper, middle, and lower lung folds. Breath sounds over the trachea and bronchi have different qualities than breath sounds over the lung parenchyma. Be sure you know the location of these structures. The trachea bifurcates into its mainstem bronchi at the level of the sternal angle anteriorly, and the T4 spinous process posteriorly. The pleura is very important organ of the respiratory systems. These are serous membranes that cover the outer surface of each lung, the visceral pleura, and also lines the inner rib cage and upper surface of the diaphragm. The parietal pleura, their smooth opposite surfaces lubricated by pleural fluid, allows the lungs to move easily within the rib cage during inspiration and expiration. The pleural space is a potential space between visceral and parietal pleura. The dome-shaped diaphragm is a primary muscle of the inspiration. Muscles in the rib cage and neck expand the thorax during inspiration. Oxygen diffuses into the blood of the adjacent pulmonary capillaries, and carbon dioxide diffuses from the blood into the alveoli. After inspiratory effort stops, the expiratory phase begins. The chest, wall, and lungs recoil. The diaphragm relaxes and rises passively. It plows outwards, and the chest and abdomen return to the resting position. Here you can see the main symptoms of respiratory systems. There is chest pain, dyspnea, wheezing, cough, and blood-stained sputum, call it hemoptysis. As in other systems, we must characterize the symptoms of these organs. There is important part about the symptoms. First, location. Where is it? Does it radiate? Second, quality. What is it like? Then quantity or severity. How bad is it? How pain the patient and feeling. 4, timing. When does it start? How long did it does? How often did it come? Setting in which it occurs include environment factors, personal activities, emotional reaction, and or other circumstances. Remitting or exacerbating factors, associated manifestations, have the patient have noticed anything else that accompanied it. Chest pain is very multiply reason symptoms. There must be involved as heart, lung, also the organs not included in the chest cavity. The main reasons of this chest pain, as you know, is angina pectoris when we have myocardial infarction. Pericarditis is the inflammation of the cover of the heart. Dissecting aortic aneurysm in these disorders, it have very severe pain here. Bronchitis, pericarditis, pneumonia, costochondritis, herpes zoster is a viral infection, reflux esophagitis, what I told about you, it's from intragastrointestinal systems, esophageal spasm, cervical arthritis, biliary colic, and gastritis. The second very specific syndrome and symptom of this respiratory system is dyspnea. It's a non-painful but uncomfortable awareness of breathing that is inappropriate to the level of exertion. Have you had any difficulty of breathing? You must ask the patient. How many steps of flight or stairs can the patient climb before pausing for breath? Has patient dyspnea altered the patient lifestyles and daily activities? How? Carefully elicit the timing and setting of dyspnea, any associated symptoms, and relieving or aggravating factors. These are musical respiratory sounds that may be audible both to the patient and to the others. It's very also specific symptom is cough. Typically, cough is a reflex response to stimuli that irritate receptors in the larynx, trachea, or large bronchi. These stimuli include mucus, pus, and blood, as well as external agents such as dust, foreign bodies, or even extremely hot or cold air. Other causes include inflammation of the respiratory mucosa and pressure of tension in the air passage from a tumor or enlarged peribronchial lymph nodes. Although cough typically signal of the problem in the respiratory tract, it may also be cardiovascular in origin. For complaints of cough, a thorough assessment is in order. Ask whether the cough is dry or produces sputum or phlegm. Ask the patient to describe the volume of any sputum and its color, odor, and consistency. The most important part of symptoms of the respiratory system is hemoptysis. The coughing up of blood from the lungs. It may vary from blood-taking or frank blood. For patients reporting hemoptysis, assesses the volume of the blood produced as well as the other sputum attributes. Ask patient about the related setting and activities and any associated symptoms. Before using the term hemoptysis, try to confirm the source of the bleeding by both history and physical examination. Blood or blood-stained material may originate in the mouth, pharynx, and gastrointestinal tract and is easily mislabeled. When vomited, it probably originates in the gastrointestinal tract. Occasionally, however, blood from the nasopharynx or the gastrointestinal tract is aspirated and then coughed out. You know that smoking is very closely connected with respiratory system disorders. At every meeting, in every time when we meet the patient, we must explain the harm of the tobacco smoking and take advice to stop smoking to patient. We must advise patient regularly to stop smoking in a clear personalized message, assist patient to set stop dates and provide educational materials for self-help, arrange for follow-up visits to monitor and support progresses. After the general things, we now begin how to examine the patient with respiratory disorders. With the patient sitting, examine the posterior thorax and lungs. The patient's arm should be folded across the chest with hands resting, if possible, on the opposite shoulders. This position moves the scapulae partly out of the way and increases your access to the lung fields. Then ask the patient lie down. With the patient supine, examine the anterior thorax and lungs. The supine positions make it easier to examination movement because the breath can be gently displaced. Furthermore, wheezes, if present, are more likely to be heard. For patients unable to sit up without aid, try to get help so that you can examine the posterior chest in the sitting position. If this is impossible, roll the patients to one side and then to the other. Even though you may have already recorded the respiratory rate when you took the vital signs, it's wise to again observe the rate, rhythm, depth, and effort of breathing. A normal resting adult breathes quietly and regularly, about 14 to 20 minutes a minute. An occasional sigh is to be expected. Note whether expiration lasts longer than in usual in some disorders. You can see here the monitor screen. We can take this picture when we are monitoring the patient. And you must know these lines here. The first is line of ECG electrocardiograms. Second is about oxygen, and the third is respiratory line. You can see here. And at last, it is arterial blood pressure monitoring here. There is a breathing patterns when we met in respiratory system disorders. In the first, you can look that is a normal apnea, normal breathing rate and pattern. Below them is tachypnea, increased respiratory rate. Then is bradypnea. It means decreased respiratory rate. Apnea, when the patient stopping breathing, absence of breathing. Hyperpnea, when the intensity of the breathing are increased here. Chain stocks breathing, it's very important part. Gradual increases and decreases in respiration with periods of apnea. It we met in case of stroke. Piot breathing, abnormal breathing pattern with groups, cluster of rapid respiration of equal dips and regular apnea periods. Kussmaul breathing is tachypnea and hyperpnea, and apneustic is prolonging inspiratory pace with prolonging expiratory pace. In this, you can then read are the same pattern of the breathing, and there is also the rhythm of this pattern. Maybe there is most important is chain stocks breathings, periods of deep breathings alternate with period of apnea no breathing. This pattern is normal in children and older adults during sleep. Causes include heart failure, uremia, drug-induced respiratory depression, and brain injury, typically hemispheric here. This obstructive breathing we frequently met in case of COPD and asthma. There is rapid deep breathing with hyperventilation and ataxic breathing, Biot breathing. Assess the patient's color for cyanosis. Recall any relevant findings from earlier part of your examination, such as the shape of the fingernails. Listen to the patient's breathing. Is there any audible breathing? If so, where does it fall in the respiratory cycle? Inspect the neck. During inspiration, is there contraction of the sternomastoid or other accessory muscle or supraventricular retraction? Is the trachea midline? And so observe the shape of the chest. The antero-posterior diameter may be increased with aging. After that, we begin inspection. From a midline position behind the patient, note the shape of the chest and the way in which it moves, including. The first we are looking by inspection is the form of the thorax. In normal adults, the thorax is wider than its deep. Lateral diameter is greater than anterior-posterior diameter. In such diseases such as COPD, the form of the chest are changed. It became round, increased anterior-posterior diameter, and you can see here that the anterior, posterior, and lateral diameter are approximately the same. The second disorders of the form is traumatic flail chest. It multiply ribs are fractured, can see paradoxical movement of the thorax. Descent of the diaphragm decreases intrathoracic pressure on inspiration. The injured area may cave inwards. On expiration, it moves outwards. Funnel chest, pectus excavatum. Depression in the lower portion of the sternum, related compression of the heart and great vessels may cause menorrhagia. Cross-section of thorax, pigeon chest, pectus carinatum. Sternum is displaced anteriorly, increasing the AP diameter. Costal cartilage adjacent to the protruding sternum are depressed. Thorax hyposcoliosis, abnormal spinal curvature and vertebral rotation deforms the chest, making interpretation of lung findings difficult. You can see how they are changed. Here we can see the other changes of the form. There is normal barrel chest, scoliosis when the vertebrae are twisted here, pectus carnitum, pectus excavatum, funnel chest, and kyphosis. Here also we have a horizontal view of deformities of the chest. I must say that funnel chest is most danger because the bone of the chest are pressed to the heart, and there may be some cause disorders of the heart, maybe some arrhythmias, heart failure, and so on. There is different change of these forms. And from here, we can see that the most spread disorders are symmetrical or asymmetrical funnel chest. Sometimes we have asymmetric expansion of the chest. We have mainly when there is large pleural effusion. Abnormal, and so we have retraction of the interspace during inspiration. Retraction is most apparent in the lower interspaces. Supraclavicular retraction is often associated. Retraction occurs in severe asthma, COPD, or upper airway obstruction. Sometimes one part of the chest are moving and another chest are not moving. It's impaired respiratory movement, one of the both sides or unilateral leg. Unilateral impairment of a leg suggests pleural diseases from asbestosis or silicosis. It is also seen in chronic nerve damage or trauma. After inspection, we go to the palpation. We are touched by our palms to the surface of the chest. We are focused on the tenderness and abnormalities in the overlying skin, respiratory expansion, and fremitus. Identify tender areas. Intercostal tenderness can develop over inflamed pleural costal cartilage, tenderness in costochondritis. We carefully palpate any area of where the pain has been reported on over the lesions of bruises are evident. Tenderness, bruising, and bony step-offs are common over the fractured rib. Crepitus may be palpable in overt fractures and arthritis joints. Crepitus and chest wall edema are seen in the mediastinitis. What is crepitus? Crepitus is a grating voice when we have fractured ribs. SSC observes such a masses of sinus tracts. The implementary tube-like structure abnormal tipping onto the skin. It is sinus tracts here sometimes. Although real sinus tracts suggest infection of the underlying pleura and the lung. Now we begin chest expansion. Place your thumbs at about the level of the tense ribs with your fingers loosely grasping it parallel to the lateral rib cage. As you position your hands, slide them medially just enough to raise the loose fold of the skin between your thumbs over the spine. Ask the patient to inhale deeply. Watch the distance between your thumbs as they move apart during inspiration and feel for the range and symmetrically of the rib cage is expands and contract. This movement is sometimes called lung excursion. Unilateral decreased or delay in the chest expansions occur in chronic fibrosis of the underlying lung or pleura, pleural effusion, lobar pneumonia, pleural pain with associated splinting, unilateral bronchial obstruction, and paralysis of the hemidiaphragm. Now let me the little video about chest expansions. If we were together in our room, we will practice it maybe on the mannequin or by the students. But let me now look this.
To assess chest expansion, there's two different ways of doing it. In the front of the chest, you're checking for outward expansion and also anteroposterior expansion. In the back, you just check for outward expansion, both at the top and the bottom. So for outward expansion, this is how you do it. You put your fingers on the skin on either side, drag into the middle, and keep your thumbs off the chest surface. And you ask them to take a deep breath in and out. And you're looking for the movement of both fingers, and they should move equally apart. That's outward expansion. If you want to do anteroposterior expansion, you just lay your two hands at the top of the chest, ask them to take a deep breath in and out. And you're looking for the upward movement, which should be equal on both sides. When I was checking expansion of the back, you may have noticed in the video that I was
We palpate both lungs for asymmetric tactile fremitus. Fremitus refers to the palpable vibration.
If you want to do anthroposophy, your two hands the chest, ask them to take a deep breath in and out. And you're looking for the upward movement, which should be equal on both sides. When I was checking expansion of the back, you may have noticed in the video that I was able to reach across and perform it in a similar manner to that which I did in the front of the chest. Quite a lot of the time, you don't have space to do this. So you actually have to reach across and invert this arm and do it this way around. And I'll show it works just as well. So if I grab, move across, and take a deep breath in and out. Okay.
Palpate both lungs for symmetric tactile fremitus. Fremitus refers to the palpable vibrations that are transmitted through the bronchopulmonary tree to the chest wall as the patient speaking. In the normal symmetric fremitus is typically more prominent in the interscapular area than in the lower lung fields and easier to detect over the right lung than the left. It disappears below the diaphragm. Fremitos is decreased or absent when the voice is higher, pitched or soft, or when the transmission of vibrations from the larynx surface to the of the chest is impeded by the thick chest wall and obstructed bronchus, COPD, or pleural effusion fibrosis, pneumothorax of the infiltrating tumor. Fremitus refers to the palpable vibrations transmitted through the bronchopulmonary tree to the chest wall when the patient speaks. To detect fremitus, use either the ball in part of the palm at the base of the fingers, or the ulnar surface of your hand to optimize the vibratory sensitivity of the bones in your hand. Ask the patient to repeat the words 99 or 9111 or balloon, 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 balloon. If fremitus is faint, ask the patient to speak more loudly or in deeper voice. Use one hand until you have learned the feel of fremitus. Some clinicians find using one hand more accurate. The simultaneous use of both hands to compare sides, however, increases your speed and may facilitate detection of differences. Asymmetric decreased fremitus raises the likelihood of unilateral pleural effusion, pneumothorax or pneumoplas, which decreases transmission of low-frequency sound. Asymmetric increased fremitus causes unilateral pneumonia, which increases transmission through the consolidated tissue. In this picture, you can see that fremitus increases during pneumonia at the left side here, and fremitus decreases in case of pleural effusion, shown at right side. From here, we can say that if they are increased here, the fremitus are increased, and if the in the volume are not here, the fremitus is decreased. Now we can see another video about fremitus.
Tactile fremitus. Tactile fremitus is a palpable vibration of the chest wall resulting from speech. Tactile fremitus may be performed in two ways. The first way is to place the ulnar surface of your hands against the patient's chest wall and ask them to repeat the phrase 99. The second way is to place the palmar surface of the fingers against the chest wall and again have the patient repeat the phrase 99. The test should be repeated from the front, again going from top to bottom. Again, have your patient say 99. 99, 99, 99, 99, 99. 99, 99, 99, 99. Tactile fremitus is increased by conditions that cause the lung to become more solid, such as consolidation, fluid, or a mass. Tactile fremitus is decreased by conditions that decrease the transmission of sound waves, such as increased fat, an air fluid level in the chest wall, or overexpansion of the lungs from emphysema.
Now, let me begin examination of the anterior chest. When examined in the supine position, the patient should lie comfortably with arms somewhat abducted. If the patient is having difficulty breathing, raise the head of the examining table or on the bed to increase respiratory excursion and ease of breathing. Observe the shape of the patient chest and the movement of the chest wall. Note deformities or asymmetry of the thorax, abnormal retraction of the lower intercostal space during inspiration or any supraclavicular retraction, and local lag or impairment in respiratory movement. Persons with severe COPD may be prefer to sit leaning forward with lips pursed during exhalation and are supported on their knees or a table. Second example, abnormal retraction occurs in severe asthma, COPD, or upper airway obstruction. Lag occurs in underlying diseases of the lung or pleura. Then we palpate the anterior chest wall for the following purposes: for identification of tender areas, assessing the bruise, sinus tract, or the other skin changes, assessment of the chest expansion. Place your thumbs along each costal margin, your hands along the lateral rib cage. Your positions, your hands slide them medially to raise. Loose skin falls between your thumbs. Ask the patient to inhale deeply. Observe how far your thumbs diverge as the thorax expands, and feel for the extent and symmetry of respiratory movement. Tender pectoral muscles or costal cartilage suggests, but do not prove that the chest pain has a localized musculoskeletal origin. Assessment of the tactile fremitus. If needed, compare both sides of the chest using the ball of ulnar surface of our hand. Fremitus is usually decreased or absent over the precordial. When examining a woman, gently displays the breast as necessary. We mentioned and now repeated the sources of the chest pain and related causes. The pain in the chest may be from heart, maybe from myocardium, when the reason is angina pectoris or myocardium infarction. Pain may be from pericardium. Pericardium when we have pericarditis. Very severe pain from aorta when we have aortic dissections. From trachea and large bronchi when we have bronchitis. The parietal pleura in case of pericarditis, pneumonia, pneumothorax, pleural effusion, and pulmonary embolus. Chest wall, including the musculoskeletal and neurological system, may be from costochondritis and the viral infection herpes zoster. From esophagus, when we have gastroesophageal reflux diseases, esophageal spleen, and esophageal tear. Extrathoracic structures such as the neck, gallbladder, and stomach. Cervical arthritis, biliary colic, and gastritis. This is interesting that pain here are not from this organ who are situated in thorax, but from abdominal cavity. It's very interesting, and you must know the problems of the chest pain for make differential diagnosis here. In case of cardiovascular angina, the location are retrosternal or across the anterior chest. It is from myocardial ischemia or from myocardial infarction. The quality of pain are pressing, switching, tight, heavy, occasion bearing. Severity are mild or moderate, sometimes perceived as discomfort rather than pain. Myocardial infarction, pericarditis, and dissected aorta aneurysm are from cardiovascular systems who are situated also in chest. From here, it's a very dangerous dissected aorta aneurysm because it often ended with death of the patient. In this case, we have a splitting within the layers of the aortic walls. We have very severe anterior chest radiating pain to the neck, back of abdomen. The quality of this pain are ripping, tearing, and it's very severe. From Respiratory systems. The most spread pain are from pleural pain. It connects with inflammation of the parietal pleura. Chest wall overlying the process. The pain are sharp, knife-like, and often severe. And sometimes the pain are caused by anxiety. The process is unclear. The location, precordial or across the anterior chest, the character of the pain are stabbing, sticking, or dull aging, and severity are variable. The most spread syndrome of respiratory system is dyspnea, when the patient cannot properly breathing. It may be from heart problem when we have left-sided heart failure. In this case, it increases work of breathing and is slowly or suddenly. In case of chronic bronchitis, there is excessive mucus production of bronchi followed by chronic obstruction of airways. It's chronic productive cough followed by slowly progressive dyspnea. Another reason of the dyspnea is chronic obstructive pulmonary diseases. It occurs over distension of air spaces distal to terminal bronchioles with destruction of the alveolar septal. It is slowly progressive dyspnea, relatively mild cough became later. Also, asthma is very spread, especially in young people. It's bronchial hyper-responsiveness involving release inflammatory mediators. It's acute, it have acute episodes separated by symptom-free periods. Nocturnal episodes are common. Sometimes we have diffuse intestinal lung diseases, what also cause the dyspnea. It's abnormal and widespread infiltration of cells fluid collagen. It's progressive dyspnea which varies of its rate of development. Very dangerous situation is when we have spontaneous pneumothorax. It's a leakage of air into the pleural space with resulting partial or complete collapse of the lung. And it has sudden beginning of dyspnea. It's very dangerous, also acute pulmonary embolism. It is sudden occlusion of pulmonary arterial tree by a blood clot. Of course, it's beginning very suddenly. Cough and hemoptysis. The cause of it is acute inflammation. In these times, you have dry cough, may become productive or variable amounts of sputum. It's associated with an acute febrile illness, often with malaise, headache, and possible dyspnea. Cough and hemoptysis we have also in chronic inflammation. When we have chronic cough, sputum mucoid or mucopurulent, often long-standing cigarette smoking, recurrent superimposed infections, wheezing, and dyspnea may develop. It's very bad when it is connected with neoplasms, some cancer of the lungs. Cough, dry, not productive, sputum may be blood-stained or bloodly. Usually, a long history of cigarette smoking associated manifestations are numerous. And as a part of the cough and hemoptysis, maybe cardiovascular disaster. Here is often dry, especially on exertion at night, may progress to the pink plotty sputum on pulmonary edema to frank hemoptysis. We have dyspnea, orthopnea, paroxysmal, and nocturnal dyspnea. Thank you for today. We finish this part of the respiratory system examination. We have only two methods today learned. This was inspection and palpation. Next times we will have percussion and auscultation. Thank you. We will meet later.